Dr. Amat, please unmute yourself first.
Assalamu alaikum. Bismillahirrahmanirrahim. I am Dr. Ahmad. Quote of the day: Freedom lies in being bold, by Robert Frost. I am Dr. Ahmad, PGR, MPH, KMU, under the kind supervision of Professor Sairad Afzal. Today, my topic is family planning permanent methods. Learning outlines, introduction, objectives, classification of contraceptive methods, male and female permanent contraceptive methods, recent advances, MCUs. First, introduction. Family planning definition. Family planning allows people to attain their desired number of children, if any, and to determine the spacing of their pregnancies. It is achieved through use of contraceptive methods and the treatment of infertility. Learning objective. At the end of this presentation, the participants would be able to describe the introduction of family plannings, different methods of permanent family planning, their uses, advantage and disadvantage. Contraception. The methods or device used to prevent pregnancy are called contraception. Contraception means prevention against pregnancy. There are types of contraception. There are two types of contraception: temporary method of contraception and permanent method of contraception. The temporary method of contraception include condom, diaphragm, chemical methods, hormone methods, intrauterine devices, and permanent method include terminal method, sterilization, which include vasectomy and tubectomy. Male and female permanent contraception. Permanent contraception, which already we discussed, include female and male. Female include tubal occlusion and male is vasectomy. First, we talk about female tubal occlusion. Tubal ligation is a surgical procedure for female sterilization in which the fallopian tubes are permanently blocked, clipped, or removed. This prevents the fertilization of eggs by sperm and thus the implantation of a fertilized egg. What is female sterilization? Permanent surgical contraception for women who will not want more children. There are two procedures which become most common. First, laparoscopy, which involves inserting a long, thin tube containing lenses into the abdomen through a small incision. This laparoscope enables the doctor to reach and block or cut the fallopian tubes in the abdomen. Second is mini laparotomy, which involves making a small incision in the abdomen. The fallopian tubes are brought to the incision to be cut or blocked. Who can have a tubal occlusion? First, women who has a genetic disorder and don't want to pass on to a child. Women who have completed childbearing and desire a non-reversible contraceptive option are candidates for tubal ligation. Women in whom a future pregnancy could pose a significant risk of medical harm. Key points for providers and clients. Permanent, intended to provide lifelong, permanent, and very effective protection against pregnancy. Reversal is usually not possible. Involves a physical examination and surgery. The procedure is done by specifically trained provider. No long-term side effects. How effective? One of the most effective contraceptive methods, but carries a small risk of failure. Less than one pregnancy per 100 women over the first year after having the sterilization procedure, 5 per 1,000. This means that 995 of every 1,000 women rely on female sterilization will not become pregnant. A small risk of pregnancy remain beyond the first year after the procedure and until the woman reaches menopause. Over 10 years of use, about 2 pregnancies per 100 women, 18 to 19 per 1,000 women. How to counsel patient for sterilization? Counseling for sterilization. Sterilization is a permanent method of contraception. Once the surgery has been performed, the individual can't simply change his or her mind. A number of circumstances usually hard to predict, may lead user to regret that the sterilization procedure was performed, for example, losing their children, getting divorced or remarried, or wishing for additional children. Make certain that the patient correctly understand the procedure and its consequences. You must tell the VSC voluntary surgical contraceptives is irreversible. Once the client has undergo VSC, it is extremely difficult for him or her to reverse the procedure and have more children. Female sterilization procedure. First, we discuss about laparoscopic procedure. This is a technique of female sterilization through abdominal approach with a specialized instrument called laparoscope. The abdomen is inflated with gas and instrument introduced into the abdominal cavity to visualize the tubes. Once the tubes are accessible, the clips are applied to occlude the tube. This diagram shows total whole procedure of laparoscopic tubal ligation. Complication of laparoscopic procedure. Although complications are uncommon, when they do occur, they may be of a serious nature requiring experienced surgical intervention. Puncture of large blood vessels and other potential complications have been reported as a major hazard of laparoscopy. Now we talk about second method, mini laparotomy method. Mini laparotomy is a modification of abdominal tubectomy. It is much simpler procedure requiring a small abdominal incision of only 2.5 to 3 centimeter conducted under local anesthesia. It is found to be suitable procedure at the primary health center level. It has an advantage over other methods with regard to safety, efficiency, and ease in dealing with complication. This method is suitable for postpartum tubal sterilization. Advantages of female sterilization. Permanent birth control, immediately effective, requires no daily attention, cost effective in the long term, does not affect sexual pleasure. Disadvantages of female sterilization: requires surgery and has risk associated with surgery. More complicated than male sterilization, may not be reversible, resulting in possible regret. Does not protect against sexually transmitted infection, including HIV and AIDS. Contraindication: ambivalent patient, lack of finances, very young age, incapable of making a medical decision, the presence of gynecological malignancy and morbidity. This chart show from the sterilization among women between 15 to 44-year age, reporting by WHO World Health Organization from 2013 to 2015. We show all women age 15 to 14 uses this method, 20%, 22% of whole population. This is another chart, the study which is held in 2019 by WHO, which shows the female sterilization user are 219 million, which make up the 24% of population. Now we talk about vasectomy. Who can have a vasectomy? Have no children or few children, are married or are not married, are young, have sickle cell disease, are at high risk of infection with HIV or another STI, are living with HIV whether or not on antiviral therapy. Vasectomy. Vasectomy is an elective surgical procedure for male sterilization or permanent contraception. During the procedure, male vasa differentia are cut and tied or sealed so as the prevent to sperm from entering into the urethra and thereby prevent fertilization of female through sexual intercourse. Key points for providers and clients. First, permanent, intended to provide lifelong, permanent, and very effective protection against pregnancy. Reversal is usually not possible. Involves a safe, simple surgical procedure. 3-month delay in taking effect, the man or couple must use condoms or an other contraceptive methods for 3 months after the vasectomy. Does not affect male sexual performance. Key advantages of male sterilization. First, permanent birth control requires no daily attention, does not affect sexual pleasure, less complicated than female sterilization. Key disadvantages of male sterilization. Not immediately effective, requires minor surgery in hospital, may not be reversible, possible regret, possible rejoining of the vas deferens, does not protect against STI, including HIV and AIDS. Contraindication, coagulopathy, previous scrotal surgery, chronic orcalgia or testicular pathology such as malignancy. Some patient may present an ethical dilemma to the physician: young age, no children, lack of agreement with the partner, current pregnancy, and possibility of fetal loss. How effective is this? One of the most effective methods, but carries a small risk of failure. Among the partners of men who have vasectomies, far less than one in year 100 will become pregnant in the first year of use of the method. In fact, less than 2 women in every 1,000 will become pregnant. This means that 998 and 999 of 1,000 women whose partner have had vasectomy will not become pregnant. Sometimes men can have their semen examined at 3 months after the procedure to see if it is still contains sperm. If no sperm is found, one woman in every 1,000 of these men's partner will become pregnant in the first year. Continue. Among partner of men who do not have their semen examined, pregnancies are slightly more common, but still less than 2 per 1,000 women. Vasectomy is not fully effective for 3 months after the procedure. Some pregnancies occur within the first year because the couple does not use condom or an other effective method consistently and correctly in the first 3 months before the vasectomy is fully effective. Why some men say they like vasectomy? Because it is safe, permanent, convenient, has fewer side effects, complication than many other methods for women. The man takes responsibility for contraception, takes burden of the woman. Complication of vasectomy. First, bleeding or blood clot inside the scrotum, blood in your semen, bruising of your scrotum, infection of the surgery site, mild pain or discomfort, swelling. This chart show the study of vasectomies which were done between 2013 to 2015 by WHO. All men ages 15 to 44 age make up the 5% of population with vasectomies. Now it's time for recent advances. First, utilization of long-acting and permanent contraceptive methods and associated factor among women of reproductive age in West Guji zone, Southwest Ethiopia. Result include the current utilization of long-acting permanent methods at West Guji zone among the reproductive aged group was found to be 51%. More than the median of participants had negative altitude 72.4% and poor knowledge 57% towards the long-acting permanent methods. Educational status of women, the number of alive children, acceptance of utilization of long-acting permanent method, how treated by other staff, and waiting time during service delivery are significant determinant factor of long-acting permanent methods. Conclusion: overall, more than half of women had a negative attitude and poor knowledge of long-acting permanent methods. Educational status of women, the number of alive children, acceptance of utilization of long-acting permanent method, how treated by other staff, and waiting time during service delivery were factors affecting utilization of long-acting permanent methods. Therefore, sustained and appropriate information or LAMP should be provided to raise knowledge and build the attitude of women and the community, treating the client with respect, reducing the waiting time, and collaborative work with health extension worker will enhance utilization of long-acting permanent methods. Now, the role of second is the role of demand of contraception in the meeting the demand for family planning in low and middle income countries. The result are in the 20 country studies between 6% and 94% of the contracepting population used modern methods. Female permanent contraception accounted for more than half of the women using modern contraceptive in India. Dominican Republic, Salvador, Mexico, and Colombia. In India, Togo, more than 20% of women using contraceptive with fewer than two living children were using female permanent contraception. Among women with two living children, countries with the highest reliance on permanent contraception were India 79%, El Salvador 61%, Cuba 55%, and Colombia 52%, and Thailand 51%. Dominican Republic, El Salvador, India, and Mexico presented high levels of permanent contraception among younger women, with reliance higher than 30% among women aged 25 to 29 and 50% or more among women aged 30 to 34. Conclusion: reliance on permanent contraception was high in several countries and among women aged less than 35 years. Now it's time for MCQs. First MCQs, there are many different methods of contraception. What is the main action of contraceptive? A, prevention of ovulation and fertilization only. B, prevent ovulation only. C, prevent rapid passing of egg in the oviduct. D, prevention of ovulation, implantation and fertilization only. E, prevention of implantation only.
D.
It's a prevention of ovulation and fertilization only. Now come to second MCQ. A man age 50 year having 5 children come to a family planning clinic for sterilization method. Doctor advised him vasectomy. He is reluctant to have a vasectomy because of A, major surgery involved, B, fear of decreased in sexual performance, C, permanency of procedure, D, cost of the procedure, and E, its complications.
C.
Anyone?
B.
Yes, B. B is the right. B is the right answer. Fear of decrease in sexual performance. Now, question number 3. Permanent sterilization is the most efficient method of contraception. Which of the following is prevented by surgical intervention? A, fusion of male and female gamete. B, synthesis of gamete. C, motility of sperms. D, transport of gametes. And E, inhibit the motility of sperms.
D.
D.
Yes,
D.
D. D. It's D, transport of gametes. Number 4, doctor advised vasectomy to a 45-year-old man who have completed his family and wants for sterilization. After vasectomy, A, intercourse should be delayed for 6 weeks. Sperm will be still be ejaculated for a month. C, erection will be difficult to maintain. D, monthly sperm count for a year will be necessary. And E, couple must use condom or an other contraceptive method for 6 months after the vasectomy.
E.
Yes,
B.
it's B. Sperm will still
E.
be B. It's B. Beta. Sperm will still be ejaculated for a month. Pregnancies per 100 women per years with male sterilization according to WHO is A1, B is 0.1, C is 0.25, D is 0.3, and E is 0.5.
B.
Yes, B,
B.
it's B. It's B 0.1. Question number 6. Pregnancies per 100 women per year with female sterilization according to WHO is A1, B is 0.1, C is 0.25, D is 0.3, and E is 0.5.
A.
No, it's
A.
E 0.5. Now, question number 7. A male came to a family clinic for vasectomy after completion of procedure. He was told that he was not sterilized immediately. He must use some other methods of contraception till at least A 20 ejaculations, B 30 ejaculations, C 40 ejaculation, D 50 ejaculation, and E is 60 ejaculations.
B. 30 ejaculations.
Yes, it's B 30 ejaculations. Now, question number 8. A 45-year-old mother of 5 children had recent abortion. She had also become hypertensive and diabetic. She seeks advice about methods of prevention of pregnancy. The most suitable methods for her is A. IUCD, B. Injectable hormones, C. COCP, D. Norplant implant, and E is tubal ligation.
E.
Yes, it's E. Tubal ligation. Now, question number 9. A male aged 48 years after 2 months of vasectomy comes to clinic with the query that last night he had an unprotected intercourse with his partner. He is very curious about the pregnancy. How would you counsel the patient? A. Give emergency pill to his partner and advise him to use condom or some other methods of contraception for 1 month. B, there's no need to worry about it. C, give emergency pill to his partner and advise him to use condom for 6 months only. D, go for dilatation and curettage. E, there's no way to revert it back.
A.
Yes, it's A, give emergency pill to his partner and advise him to use condom or some other methods of contraception for 1 month.
Next, please.
Okay, ma'am. Now, question number 10. A woman aged 45 years after 1 year of tubal ligation, she comes to clinic with positive pregnancy test. She has a positive history of STD 1 month back. What should be the possible cause? A. Ectopic pregnancy. B. Lab error. C. zero point 0.5 pregnancy per 100 women per year with female sterilization according to WHO. D. Both A and B, and E is STD.
C.
No, it's D. Both A and C. Both are the possible condition like ectopic pregnancy, and also the C option is 0 0.5 pregnancy per 100 women per year. This is the key, and thank you very much.
Okay, thank you very much, Dr. Math. You have done a lot of hard work in your presentation, and I can see that there are very good use of graphics in your presentation. You have also presented recent advances. However, I think that more of the slides should be on recent advances. Third thing is about MCQs. In MCQs, if you please go to your MCQ number 9. Would you please like to go to your MCQ number 9? Okay. This is number 10, number 9. Okay. You can see the option A is a very lengthy one, and this is not homogeneous with the rest of the options. So all the options should have the same sentence structure. They should be short and brief, and they should also look alike. Similarly, if you go to your next MCQ, we know that in MCQs, we should not use any option, all of the above, none of the above, both A and B, etc. So in this options, you have used both A and B. Similarly, in your first and second MCQ, if you please go to your first and second MCQs, please. Right. This MCQ is much better than the rest of the MCQ. Next, please. Again, here you can see the options are almost alike and they are homogeneous except for B, that is little lengthy one. Next, please. Okay, this is better. Next, please. Next, again, you can see that in E, you have in the previous MCQ, again in E, you have a very lengthy option and that is not like the other options. So it is standing out. Next, please. We should avoid the MCQs with numbers, right? So again, there are certain numbers that has to be